already a strong evidence base on the value of IVUS in peripheral arterial interventions. But the problem is IVUS is used rather inconsistently on a case-to-case basis. IVUS can be used to assess a vessel for its size, the type of disease within a vessel, and also to assess the vessel after intervention. The first thing we did was carry out an extensive scope review of the literature, and we found that IVUS was being used quite inconsistently. So the aim was to ask international experts in vascular surgery, cardiology, interventional radiology and angiology to provide clarity on how IVUS should best be used in our current practice. We used the literature from the scoping review to construct our statements for the first round. We ensured that there were strict thresholds for agreement and that these were consistent across rounds. There was actually a lot of strong agreement after round one. And following a round table, we were able to come up with a new set of statements for round two. And overall, we now have 33 recommendations from the Delphi. The key finding was that there is a clear workflow on how IVUS should best be used in order to make sure it's used consistently across procedures. So we found that users recommend that we should first scan and plan the treatment with your first IVUS pullback, assess the vessel and choose your device based on sizing and the type of disease in that vessel. And following treatment, IVUS can be used to recheck that vessel to make sure that you're happy with that treatment and bail out if needed with stents and appropriately sized stents based on the IVUS measurements. And finally, part of the workflow recommendations is that IVUS should then be used to check your procedure at the end as your quality control. So what was really unexpected was, despite IVUS being used by a range of specialists across a range of healthcare systems, there's actually a clear workflow in how IVUS is being used. Specialists are clearly using IVUS to sort of see and then treat these vessels, plan accordingly, and once they've treated the vessels, to reassess those vessels after using IVUS. And IVUS is again being used to bail out where needed. What was also unexpected was that we're hoping to come up with a threshold to allow clinicians to understand when their procedure might be complete. However, our expert panel was very consistent in that IVUS should be used to assess the image, use that image to choose your device, but however, it's a clinical judgment that then determines at which point your procedure is finished. And it was really refreshing to see there was a real balance between enthusiasm for IVUS and clinical judgment. To summarise, our expert panel recommends that IVUS should first be used to scan and plan your treatment. Those findings should then be used to treat the vessel appropriately, and finally, when you're happy with your treatment, it should be used to check the vessels for quality control. I hope this consensus allows IVUS users to really optimise their workflows for their patients today, whilst we continue to add to the strong evidence base for tomorrow.